Hi, hello everybody. It's an honor to be here with all of you to share a few thoughts around the way in which we can think about the TB services using what happened during COVID, but also thinking for future. As you might be already aware, TB was heavily impacted. The TB response was heavily impacted by the COVID-19 pandemic. There was a heavily dramatic situation in the fact that the number of people with TB that were diagnosed and treated globally dropped in 2020 and continued to be dropped in 2021. There are signs of recovery now in the first months of 2022, but still a long way to go till we were where we should have been. As you probably heard already, there is, for the first time in the last 10 years, an increase in TB mortality. And we also have data coming from several countries, such as India and South Africa, on the COVID mortality increased due to the co-infection with TB, as well as a post-COVID activation of TB, which is a potential threat. The dramatic situation, I will explain a little bit more, conducted us to be in a place for TB right now as we were in 2012 in terms of the epidemiology and in terms of the coverage. More than that, as again, I imagine you are aware and you are all facing it or faced it, the TB capacities, the TB resources in terms of human resources, as well as the finances, but as well as the diagnosis, hospitals and dispensaries were heavily shifted to COVID. And in some of the Asian high burden countries are still remaining shifted towards the COVID situation. I will not go over all this. The slides are available for everybody. These are the graphs showing the TB notifications in 2020 and in 2021 in some of the high burden countries for TB, in showing the drop and then the tendency or the try to recover and to go back to the pre-COVID data. This is a more detailed slide on India. We can have such a detailed slide from India because India is the only country which for TB has live data. We can basically connect now and see what happened in terms of TB data, in terms of TB, people with TB diagnosed and treated as of yesterday. And we can produce this kind of graphs that are monitoring much more rapid the change in the trends, and therefore actions can be taken more rapid. It helped a lot, this situation in India, because in the first months of COVID, when the team of the national program and the Ministry of Health realized that there is a drop in the number of people with TB diagnosed and treated that is significant, they were able to come together and produce a plan on how to address and maintain the focus on TB in such a dramatic situation as COVID. You see here the data for Bangladesh. What is remarkable in Bangladesh as well as in India is the fact that currently, as we speak now, in April, May 2022, we have the data basically showing that there is a bounce back to the pre-COVID era. And this is the news that we all need to see and to deal with. I will not go into big details on this slide, which basically enumerates the reasons of the setback for the TB services during the COVID pandemic. But these are important because basically they need to be addressed if we want to go back and if we want to maintain the programmatic focus for TB. It was, as I said, the closure or diversion of health facilities, including private clinics, towards COVID. As you know, the lockdowns, the transportation of people, of specimens, of drugs was heavily impacted. Human resources and infrastructure, which was anyway limited in TB, was even further depleted. We noticed an increased stigma towards people with respiratory symptoms such as cough. There was, and the combination of TB and COVID, or the thinking that people might have TB and COVID, increased stigma and increased isolation of people affected. That's why we had a dip in the TB notification, as I mentioned, globally. In 2020 and 2021, we are at 25 to 30% drop, much bigger for people with drug-resistant TB. The other reason was the fact that even finances for TB programs were diverted towards COVID, and the research, the enrollment and trials, and the progression and advancement of work in getting, for example, a new vaccine stalled during COVID. But with all these things, we need to keep in mind that actually TB and COVID, which are two airborne diseases, with TB being much older, are having a very similar features, sorry. The symptoms are pretty similar, are not identical, but are pretty similar. Diagnosis and the PCR diagnostic platforms are as well doing TB as well as COVID, as well as others. There is a similar approach in the that can be applied for both TB and COVID towards test, trace, and treat. The human resources that are dealing with TB are very well trained and equipped and able to deal with COVID. And the fact that all the measures in terms of airborne infection control, including administrative airborne infection control, are similar. This is why, as I was saying, basically a lot of the TB units and staff were at the forefront or the baseline of starting the COVID response, because hospitals and dispensaries have somehow, not everywhere, the flows organized, some infection control measures. There was the habit of wearing a mask. Actually, us in the TB world, we asked for the mask to be used for years. It took to have COVID for people to be able to put these things in practice. But the purpose of this presentation is not to cry about COVID, but to also to speak about what are the things that can be put in place to address and continue the programming of TB in the context of the COVID. And there are things that can be done around the case finding, around the support for people with TB, as well as around the health systems. So, this is a slide that a lot of colleagues from the TB community discussed and presented. Basically, we need to maintain the active finding of people with TB. And one of the measures that we promoted a lot from the Stop TB Partnership and a lot of partners is the bidirectional testing and screening, with contact screening and testing, and with a special strategy for different locations, and with a strong engagement of the private sector. People with TB and those with COVID will definitively need support. It's not easy to do support in this kind of situation, so virtual care is extremely important, support to provide, but also support more concrete as food and financial, and also trying to basically facilitate and make the life of people as easy as possible, and basically come with the services, with the diagnosis and treatment as close as the front door of people, in facilitating basically the sample collection, the delivery of drugs, and make the life easier of all those that are sick. And that is possible either through a heavy engagement from the communities or from the health system, ensuring that primary healthcare, different units of hospitals that can be opened as close to the periphery as possible, that ensuring as well as the personnel is wearing protective equipment, that these are some of the means and the ways in which basically was possible to fight in the same time TB and COVID. I spoke a little bit about simultaneous diagnostics testing by directional screening and testing. And You know, these slides were prepared somehow in 2020, the idea of them, and then we refined later in 2020, and we promoted a lot over the 2021. But you see, now we are in May 2022, and we are observing the end, more or less, of the COVID pandemic. And we need to think of future airborne pandemics. And we need to think that things that were put in place for TB were useful for COVID, that whatever we did for COVID is helping the TB. This bidirectional testing can apply for any airborne disease. Is basically once you have a germ that goes through nose, will end up in the lungs. And then TB is there, is exactly on the same path. So the moment you have somebody which is coughing or having some fever and some malaise, there can be developed an algorithm that if there is any risk of that person having COVID or having obviously any other airborne infection, but TB, the best way is to ensure that you test both. It cannot be done a blind test like everyone that's cough is getting all possible tests, but through a questionnaire and the proper algorithm developed at the country level, you can do a proper detection of people with TB, with COVID, and any other airborne infection. Doing rapid molecular tests for those with symptoms and higher risks for TB, and obviously proactively do COVID-19 tests for people with TB. And one important piece is ensuring that in specific population groups, this is done more systematic, but also actively screening for TB among people that are recovered from COVID-19 and have prolonged respiratory symptoms. We observed that a lot of people having some, not a lot, people having some respiratory symptoms after COVID was actually due to tuberculosis. One other important aspect to keep in mind, in addition to the bidirectional testing, is the important use of digital health technologies. Digital tools for screening and diagnostics, such as radiology, such as teleradiology, such as chest X-ray, the laboratory connected tools are extremely important because will basically facilitate diagnosis for people as close as possible to their housing, as close as possible to them, without putting them through the efforts of reaching the services. It's important not just for diagnosis, it's important for patient care and for adherence to treatment, because there are many digital adherence platforms, video supported treatment, medication sleeves, smart pill boxes, to ensure that people will not have a tendency to abandon the treatment, and actually empower the people with TB to be the ones basically securing that they finish their treatment. There are as well program management digital tools, and there are as well tools that can be used by the community to really measure the engagement, as well as and monitoring of the programs, as well as obviously interaction on social media. So having these tools in place, having the mindset of doing in the same time TB, COVID, any other airborne infection, it is extremely important to put in place another component which is related to the community and private sector. Community volunteers, community workers, well paid, properly equipped, and well trained, are the golden standard and are the best supporters for a program. Go as close as possible to the community, engaging the community. They can do virtual support, nutrition support, economic. They can do the connection to the TB program, help to prevent the stigma and discrimination, can help with the monitoring and with the engagement. If we would have in place when COVID started, as we were trying for TB everywhere, we had in some places, but if we had everywhere community health workers and volunteers in standby, and ready to receive the equipment, ready to receive the training, but knowing their community and being able to go one by one at the front door and help with all of this, we would have been in a very different place. And that's why we as Stop TB pushed a lot for investments to happen in this area, that we leave something behind that is able to fight for future pandemics that might come. And we don't just do some investments that are done and then we remain in the same limbo when something else comes. The same can be to a certain extent about the private sector, because there is a lot of virtual care for TB patients organized by private sector, as well as private pharmacies that are really good, that can help as well in the programs. I have here some resources that might be useful or not. We have a lot of data from Stop TB partnership on what happened at country level. And there are some amazing examples, as I said, in Asian countries in trying to bounce back, in trying to take community workers that were for TB or MDR TB and doing very well COVID. So it's a lot of enthusiasm. It was a lot of enthusiasm and hard work that was done by the TB healthcare workers, providers, and communities in trying to fight both TB and COVID. But my plea and my last point before I close is to say that, you see, I am afraid, as I said in March 2020, that COVID will come and go and TB will remain here, as it happened over the hundreds of years since we have tuberculosis. With COVID, not only that COVID came and left, it left TB at a situation which is worse than in 2015. It's like, as I said, is the level of 2012. That's why we cannot afford to lose the situation with TB and COVID from our eyesight. And we should be smart enough to ensure that while investing in one, we help the other and potentially others. There are a lot of discussions currently on global health architectures, on funding pandemic and preparedness response. The plea that we have is, as TB helped to start the COVID response, as TB and COVID are both airborne, and there are so many similarities and so many tools to address both, let's make sure that when we discuss pandemic preparedness, TB and the interventions are there. I want to thank you all very much for giving me this opportunity, and let's see the questions and answers. Thank you.